Ready? I'm recording the session now. Okay. So you're welcome. This is our third new network presentation at Kasangati. So we're going to start with the presentation, then we shall do a bit of discussion at the end. Yes, this time we're using a PowerPoint presentation. The slides are a bit many, but it's the same routine that we've been doing. So, and I had sent the copy earlier. Yes, so it should be easy to follow. Can you see the slides?
Yeah, I can see them. Daisy, yeah?
Yes, we are.
But Daisy, before we start, who's completing the template today? Or taking the notes to enable us to complete it?
I'll be doing the template.
Okay, perfect. You're multitasking then.
Yes.
Okay, thank you, Daisy.
When we have the discussions. Okay. So, during the start? Yes. Yes.
Hello everyone. Once again, I'm called Baba Storin. I'm midwife at Kasangati Health Center 4. Our today's case presentation, neonatal sepsis. The client's initials, NS, age 29 years. She's a businesswoman and she stopped in senior 2. She's married and she was coming from Kasangati Chanchima. Religion, she's a Muslim. I'm Uganda by tribe. She was a gravida 4, para 3 plus 0. Her LNMP was December 2023 and the EDD September 2024. Weeks of amenorrhea, not known because she did not provide the exact date. The baby was admitted on 10th of October 2024, and the time of admission was at 10 p.m. and the date of delivery was at 9th of October 2024. And this baby was discharged on 12th of October 2024. The mother brought in the baby complaining of this was a 1-day old neonate who was brought in on 10th of October 2024 with complaints of failure to breastfeed, overcrying, and having high temperatures. This mother gave a history that she had delivered on 9th of October 2024 at around 4 p.m. from the traditional birth attendant's home, that is in Ginger district, who also assisted her in the delivery. She also says she started feeling back pains without any other sign at about 6 a.m. and this made her to go to the traditional birth attendant's home. On reaching there, she was examined and was given herbal tea and admitted. After some time, her membranes ruptured and she was re-examined. The TBA then decided to put her on IV fluids to help her get contractions. After some time, she called the TBA as she felt the baby was coming out. The TBA re-examined her to confirm and helped her deliver the baby. She delivered a male baby with a birth weight of 3.6 kgs. This mother was discharged from Ginger in the morning. That was on 10th of October 2024, but the baby's critical condition made her come to the hospital before going home. She reached the facility at around 11 a.m. The baby was exposed and tepid sponging was done. The temperature reduced after the interventions. The midwife educated the mother about breastfeeding, reduced the baby's clothes, and advised her to go home as the baby's temperature had stabilized. At around 8:30 p.m. on that same day, the mother reported that the baby became so unwell, developed a very high temperature, and refused to breastfeed. This prompted her to return to the health facility where the baby was later admitted due to early onset of neonatal sepsis. Her past obstetric stroke in history. This mother had no history of ectopic pregnancy or abortions. Her firstborn was delivered in 2012 by cesarean section due to preeclampsia at Kayunga Hospital. She delivered a female preterm baby of 1.7 kgs. The second born was born in 2024, in 2014 via SVD at Kayunga Hospital. A female with birth weight of 4.2 kgs. The third born was delivered in 2018 via SVD at Kangulumira Health Center for a male with birth weight of 5 kgs. All the three children were alive and healthy. Her antenatal history. She had 5 antenatal visits at Kasangati Health Center for starting at 18 weeks of gestation. That's approximately 4.5 months. She only tested for HIV status and did not test for Hep B RPR. She reports to have had 3 ultrasound scans done. This mother received the routine medication, IPT, Fefan, Mabendazo, and TT. She also reported having abnormal discharge during her pregnancy, but was told that it was a normal discharge. This mother, the doctor reviewed her and was sanctioned by the doctor for an elective cesarean section during her last antenatal visit due to previous scar and big baby. Her medical history, she had no known chronic illnesses in the family except for the pregnancy-induced preeclampsia for the first pregnancy whereby she had a cesarean section. Her surgical history, she had no past surgeries. Her family stroke social history, she had no known family history. Her mother is a businesswoman who sells roadside chips and chicken. She doesn't drink or smoke. Thank you so much. My colleagues start from there.
Thank you, Doreen. Thank you, Doreen. The baby was brought into hospital on 10th of October 2024 at 8:30 p.m. with complaints of failure to breastfeed, high temperatures, and overcrying. Physical examination. On examination, febrile, excessive crying, vital signs, temperature was 39, heart rate was not documented, respiratory rate, it was also not documented, impression, a 1-day-old neonate with features of early onset of sepsis. The plan, initiate on IV antibiotics for 3 days. On day 1, at 11 p.m., IV ampicillin 3.6 mils, IV gentamicin 1.8 mils, IV dextrose 10%, 20 mils. At 11 a.m., IV ampicillin 3.6 mils and IV dextrose 20 mils was given. On day 2, at 11 p.m., IV ampicillin 3.6 mils, IV gentamicin 1.8 mils, and IV dextrose 20 mils was given. Then at 11 a.m., IV ampicillin 3.6 mils, IV dextrose 10%, 20 mils was given. On day 3, at 11 p.m., IV ampicillin 3.6 mils, IV gentamicin 1.8 mils, and IV dextrose 20 mils was given. At 11 a.m., IV ampicillin 3.6 mils and IV dextrose 10%, 20 mils. A baby was discharged on 11th of October 2024, 12th October 2024, after received IV antibiotics for 3 days. Positive aspects: baby received antibiotics and dextrose for 3 days. Documentation of all the baby's treatment was recorded in the charts. Negative aspects: later initiation of antenatal care had a delivery conducted by a traditional birth attendant that both put the mother and the baby at risk for several complications. The IPC measures of the traditional birth attendants are questionable. Using public means expose the baby to infections.
Thank you so much. So that was our case presentation. I don't know if we have some discussions or we should just go to the template straight away.
I've got a couple of questions, if it's okay, Daisy. But it doesn't necessarily relate to the case. It's more about the system. So firstly, I was a bit confused about the role of the traditional birth attendant, because am I understanding correctly that the woman was kind of treated by the TBA within Ginger Hospital, or was it outside in the community?
Ginger District.
Oh,
It is
Ginger
in the
District, not within.
community.
Ah, right, okay. But why is it normal for a TBA to administer fluids, IV fluids?
It's not.
So did this TBA treat the woman in her I think it said she treated it in her house, but she still had the facilities to be able to provide IV fluids in her own house? Okay. Is that normal?
It's not.
No. My second question was about the locations, because she saw the TBA in Ginger District. She had her previous babies in Kayunga. And I think you said she lives near to Kasangati. So why did she have why is the TBA in Ginger? And then why did she not have this baby in Kayunga? Why did she end up going to the TBA and then to Kasangati?
She was sanctioned, so she had the Caesar.
She never
That's why
wanted
she
to be done a cesarean section, and she decided to go to have a normal delivery.
Right. So she decided herself then not to have a cesarean section. She wanted a normal delivery, and that's why she went to the TBA instead. Right. Okay. Did she know the TBA? Was it someone that she was familiar with, do you think? Or
I think she was familiar with the TBA. She knew that.
I was just wondering why she would travel all the way to Ginger District to see the TBA instead of seeing a TBA around Kasangati somewhere, but that makes sense then.
Ginger is not really far from here. It's like an hour or an hour and a half. But then
It's still a long way to go if you're pregnant, and there's many TBAs based around Kampala.
But the TBA, usually there are people who are known by the community who can do that. It's not legal. So I think when she had a challenge in the hospital, maybe someone advised her and she went there. Yes, to be assisted.
The TBA is illegal. It is illegal if this woman is called delivering any mother in the community can be even maybe sentenced. Like, yeah, it's illegal. But people just do it like illegally and hiding, and they will not really like tell these women to mention to the other people.
Okay, that helps. Thank you. I can see Rachel's got her hand up.
Yes, Rachel.
Yeah, thanks so much, Daisy and the team. Yeah, I want to talk about the TBA. What I remember during that time when it was for my diploma in Kampala, in the whole of Kampala, actually they told us that there was only one TBA, like where we went like for an interview. So maybe adding on what Stella said, that TBAs, they discourage them here in Uganda. So mothers go there secretly. Even actually, there was a scenario that happened recently. A mother went to a TBA. They delivered the baby, but the placenta failed to come out. So the TBA disappeared and left the mom bleeding, like in clots of blood. So that's when the neighbor had to call a health worker around Kampala to go and rescue. So like they are trying to discourage TBS. So another thing is that these TBS, they are there, but they are very few. Even they work in separate places. But these community members, they connect themselves. They know that if you want to go to a TBA, this is the number. So that's why like they don't want to. That's why they do them in secret. Yeah.
Thank you so much, Rachel. Any other questions? Tim, did you have any other questions?
Not really. I think the questions that I have now will come when we come to complete the template.
Okay, then I think we can go to the template. Huh?
Yeah, unless Rachel, do you have any questions about the case, or Alan?
So far, no question, but I think they will come as we go through the template. Yeah, I go with James' suggestion.
Yeah, sure.
Or Lauren in the background. Any questions?
No, not
So this is our template.
Oh, you filled it in already, Daisy?
Sorry?
You've completed the template already?
Yes, we try to put in some of our thoughts, but yes, the team will keep adding on as we are discussing.
Sure, that's very helpful. Thank you.
So I'll just move straight away to the questions. Yes, was this an appropriate mode of delivery? As a team, we agreed that it was, and the reason was the mother was able to push. The circumstances under which this happened, however, really questionable, and we don't agree with them. But since she did not get a tear and all that, we thought that it was maybe an appropriate mode of delivery. I don't know what the other team thinks.
Yeah, this is one of the questions that I had actually, because I know, for example, in the UK, if a woman has had a cesarean section, then they are very happy for her to have a normal vaginal delivery, as long as her body is looking okay. But in Uganda, I thought the policy was that if a woman had had a cesarean section previously, then they should automatically have a cesarean section for subsequent babies. But maybe I've misunderstood that.
No,
Not really.
It's not.
it depends. It depends. If maybe the other time it was about the big baby, right now they would really consider and see, is it again the same intention? Is it a big baby? And secondly, if it is maybe a fresh scar, like maybe before 2 years, so they would really like sanction this person immediately for another cesarean section. But if it's not that, and maybe it's not about the pelvis, they would really like give a try to this woman and not the previous scar. So it's not like the first cesarean section would be like the same going on. No.
Yes.
So why was the woman sent for a cesarean section? She was recommended for a cesarean section, right? But then she ran away because she didn't want a cesarean. She wanted a normal delivery. So somebody, I assume a doctor, must have recommended a cesarean section for her.
Yes.
That's the big baby.
According to the history of this mother, she had had a cesarean section before, but also the babies that she kept on having were in 4.5 kilos. Those are actually really big babies. So in most cases, she's at risk of having still a big baby. That's why they sanctioned. But still, like Stella has said, there is always trial for vaginal birth after cesarean section. So it's always better for a woman to come to hospital. There are still people who can be sanctioned, but then they end up pushing in case she comes in and they see, okay, she can actually push. But it's better for you to be in the hospital, in that if you fail to have a vaginal birth, it's easy for you to be taken to the theater for you to be scissored. So she really put herself at a risk.
This one was a big baby.
Yeah. So if the midwife or doctor had advised her to have a cesarean section based on her history, and then she went and had a vaginal delivery, was this an appropriate mode of delivery because it went against what the midwife and the doctor advised? I'm only asking because I assume they advised based on the patient history, and so they made a clinical judgment, and yet she didn't do that.
You know, like Jen, sorry, I was still like, we were still talking. Like she had the first baby was cesarean section, but the next two was vaginal delivery, but with the big babies, with the history of big babies, 4.3, 5 kgs. So the last one was also like a big baby. So the doctor was like, wouldn't really like let this person maybe push this baby, and maybe from even like she was almost nearing to the post-term dates, like the dates were really like running out. So that's why it was sanctioned. But on top of that, if a doctor sanctions you, you have a chance to be given a trial. But because she did not already, in her mind, she already had this, like they're going to do cesarean section, she ran away. She did not come back. But if she came to the hospital, I think they was going to give her a trial. Then if it fails, immediately the doctor will be aware because he had already sanctioned this mother.
And even to
Right,
add to
okay,
that,
so
most of the doctors, they don't give a chance for a mother who had the cesarean section before for the weight, when the weight goes beyond 3.8 kgs. So they don't give them a chance, these mothers, to have a normal vaginal delivery.
Okay, sorry, maybe I misunderstood then, because I thought she had been recommended to have a cesarean section already, and she went against the advice. But if she hadn't been recommended that, then I understand the answer then.
Actually, I think you got that right. She had been recommended, but there is always an opportunity for you to try within the health facility. They can review you when you're at the health facility, and then they see if you can still go in. But chances were high that she was still going to get a cesarean if she had come in. So she actually went against the instructions.
No.
So I think we might change that to a no. Yes.
If that is the clinical
Maybe.
advice of the clinician, and based on her history and based on the fact that she was probably going to have a big baby, but then she had a vaginal delivery, then I would say the answer is no, because that goes against what the clinician recommended. Sorry, Rachel, I know you were trying to come in there.
It's okay. I was just trying to give a scenario saying that actually that thing is common even this side. It was last month a mother came in with she was operated 3 times, but they're going to operate her again, but she decided to run to a private medical center in town. So when she reached there, she told them that she was operated once, and they started augmenting, like monitoring the pregnancy, and this mom, like she got a ruptured uterus, and by the time they brought her back to the hospital where she ran from, she was actually she died on table, because they had recommended Caesar for her, but she didn't like it, so she decided to run so as she can have a normal delivery. But we later lost her, so it's also common this side.
Okay. I think I would give a yes. I would really support a yes. Yeah, because the truth is, even if she came here, even if she was sanctioned by the doctor, still she was going to be given a trial. So if she pushed from here, it is a mode of delivery. I would really give a yes.
So maybe
Okay.
we can.
So perhaps on the form, why don't you put yes, and then maybe just add like in the brackets, Daisy, or something, just say this was against the clinician's advice, but still acceptable.
Yes, I think we are going to add that. Okay. So the next question, were there any risk factors for neonatal sepsis? I think yes. The risk factors, first of all, like we earlier mentioned, we don't really trust the IPC measures that the TBA used. That's a very big risk factor. We talked about the public means that the mother used. That also put the baby at risk of getting a sepsis. Yes, I don't know which other risk factors that members think about.
Daisy, for the risk factors, we were using the ones that we'd identified from the literature. I think if you scroll up on the template a little bit, they have the list of the risk factors there. If you go up.
Up?
Yeah.
Okay.
So yeah, so these risk factors are the ones that we identified from the literature. So we only need to look at these ones really. Yes.
Okay, so for the maternal urinary tract infections, she talked about a discharge, but it turned out to be normal. That's what she was told. For prolonged rupture of membranes, we cannot ascertain this because it was not documented and she had the delivery from the TBA. Then offensive smelling liquor, still this is uncertain for us. Prolonged labor, we can still not really comment about this since she had it from the TBA. Then intrapartum maternal fever, still this, we don't have like clear information about this. Then the multiple vaginal examinations. She had talked about being examined, I think, about three times. But that's what she remembers. It wasn't documented. Then the meconium stained liquor. This, we also don't have records of this. Maternal sexually transmitted infection. She didn't have any recorded. Abnormal vaginal discharge. This was not the case. The discharge that she had was normal. That's what she said. And then for the neonate, this baby was at term, so they were not premature. And then resuscitation at birth, this did not happen. Low birth weight, the weight was above 2.5 kilos. Then the APGAR score, we really cannot tell because
resuscitation, you're not sure.
Yeah, actually even resuscitation, because she did not have the birth from the hospital. Then for the socioeconomic, the low socioeconomic status, do we really think that this person was constrained? No, because maybe using public means.
To me, if she's a businesswoman who sells, I think you said she sells chicken on the road.
Yeah.
For me, that would be someone from a low socioeconomic background. I think it would be classified as, and especially like you say, the other indicator is that she's using public transport.
Yes. I think maybe she,
I think you also add it there because you're not sure. She did not do your analysis. No one really examined
okay. So for our discussion here, she had talked about a vaginal discharge. So we can put that as a risk factor, abnormal vaginal discharge. Then also we are taking the low socioeconomic status as a risk factor. For the other conditions, we can really not ascertain because the birth was not carried out at the health facility.
Yeah, maybe make a note of that, Daisy, on the template. So you can just say unknown because the delivery was with a TBA at home.
Okay, so James, you had said we look at these risk factors. So I think we can go back to the questions.
Yeah, so of these risk factors, the only one or the ones that you've mentioned, well, I heard Stella mention the UTI was a questionable one because there was some potentially offensive smelling liquor. And then the low socioeconomic status. Were any of the other risk factors identified? I don't think they were they?
We talked about IPC. We don't know if this TBA used gloves, okay, surgical gloves to do the delivery, these vaginal examinations that she was doing. We don't know if she was observing a septic technique. We talked about
these risk factors on the template. We're only looking at these ones in the table. We're not looking at other ones.
Okay, it's fine then.
Yeah.
So we can proceed to the next question. Mother have any
but you need to list the ones in the template that were discussed. So the low socioeconomic status and the potential UTI. If you can put them in the template here.
Yes.
Perfect. Perhaps on the UTI, put in brackets unconfirmed as well, because it wasn't confirmed by a test, was it? Or suspected, maybe.
Okay. Is that okay?
Yeah.
Okay. Then did she have any prophylactic antibiotics? Nothing was documented, so we said no. Were the number of vaginal examinations documented the same as the ones that the mother reports? We have no evidence of this. Then what were the baby's presenting symptoms that triggered referral to, this is supposed to be what?
I thought the vaginal examinations were not documented, but they were reported, weren't they? So she was,
Yes.
I guess we don't know how many exactly.
Yes, because the question is, were those that were documented the same as the mother reports? So we only have the mother's report. We don't,
yes, okay.
Maybe no evidence of documentation. So what were the baby's presenting symptoms that triggered referral to the ward or admission to ward? Failure to breastfeed, irritability, and high temperatures. Then were there any measures taken for the baby on postnatal e.g. exposure, skin-to-skin feeding support, full set of vitals and repeat vitals. So yes, the mother talked about exposure, talked about tepid sponging, and vitals were recorded at least on admission. So, but it was not a full set. So maybe temperature recorded on admission. Yeah.
Yeah, that was one of my questions. Why you said the heart rate and heart rate was not taken and respiratory was not taken either. Was that because there was no equipment, or what was the reason for that?
Yes, there is a stethoscope which you can use to take respiratory.
That's oximeter.
But there is a stethoscope.
Maybe a lack of some equipment, but I don't know the other reason. Maybe the midwife.
That is good.
But yeah, you said you have a stethoscope, you have watches on the phone.
You guys are smiling there in the room, so I think I think there's something that you're not sharing here.
Some standard care.
Yes, Darren, do you want to comment?
Not really. So we are missing some of the equipment, like the oximeter, we don't have it. The temperatures, the thermometer. We have just received a thermometer. That's why we didn't have.
Yes, but with the thermometer, the temperature was recorded only once. Only once. There is repeat vitals.
We have poor recording. Poor documentation.
Poor documentation.
Yeah.
Someone
records and
Is it the documentation, or is it that the vitals were not done? I think we have to be honest here. This isn't to catch anybody out. It's just to learn what's actually happening. So, were the vitals done and not recorded, or were they not done?
Sometimes it's done, but some people don't want to document.
No, they don't want, but it's a habit. It is a habit of not documenting, things. And other things, it can be both, not taking and not documenting. So, yeah.
they just touch and feel.
We are at a standstill here.
And then another thing is, another challenge is when these mothers come babies and they are admitted, the ones with sepsis, most times when they are put into the other postnatal ward of normal delivery, it becomes hard. I've seen people always take thermometers and BPs when they take the ones for cesarean section, and they end up forgetting these babies this time. So that is also another thing.
By that way. It's true.
So if in case maybe there is a baby this side, it's better to do a very keen report about it, so that people can be remembering about the baby.
So after that discussion, what do we put?
You put poor documentation and failure to
Follow up.
We are putting both because both happen.
So we are adding poor documentation.
Yeah, I would
Maybe
add that,
be
Daisy.
some work done. We have to follow up poor documentation and also not doing the not taking the vitals. Okay, so we go to the next question. Was this an appropriate admission to ward? Yes. Were there any delayed or missed episodes of care, e.g. vitals, medication? So from our discussion, we said, yes, there were some delayed episodes of care. Okay, all the antibiotics were given. I remember in the previous discussions, we said, okay, we're supposed to do 5 days, but if we can do 3 because of the so many numbers on ward, at least 3 is good if a child can get that complete set of 3 days. Say what? I think they said 7 in the first 5 to 7. If I don't yeah. But I think there's a Rachel working on it. Maybe a quick question. I know Rachel. Okay, all of us have been looking at the guidelines. Shall go back and so no. No, I'm getting
You can get it on the app. It's okay.
Okay, so let me just read what we have here. So yes, the antibiotics were given for the 3 days, and then no, the vitals were not routinely done, like we've mentioned earlier. And the IV dextrose that is supposed to be given at least every 2 hours was only given once, I think twice a day. But then our discussion was, in case the babies come in when they're not breastfeeding, usually they give the dextrose as sugar to like compensate when they don't have like enough sugars. So maybe as the baby kept on progressing and picking up, they may be picked up and they reduced the frequency, but that was what we were thinking. Maybe that's why they only gave it those few times.
Daisy, can I ask a question? So I've turned my camera off because the signal was a bit weak. So on the antibiotics, I thought usually antibiotics are prescribed for 5 days, not 3 days. So why in this case was it only 3 days, not 5?
Yes, I think this is a discussion that we've constantly had.
I think we have to check the clinical guideline of Uganda, what it says. But most times, I think we have been doing this as 3 days, and the babies have been really doing well. And I don't think we have realized creating, but it must be a very correct thing in the clinical guideline. We have to cross-check again, maybe, and see.
Here in Fort Potro, every time we have been holding this case presentation, we have been with Dr. Gloria, the pediatrician. So she says that it has to be 5 days. So here we are following 5 days, and that's what the guidelines say.
So thank you, Rachel. So in that case, then the antibiotic course was not completed because it was only 3 days, not 5.
Yes, but like I was saying in our previous discussions, we've come to a conclusion that sometimes because there are so many numbers, usually when the baby like tries to pick up and they've been given like for 3 days to create more space for the hands who are sick, usually they get 3 days and then they discharge them on syrup, like antibiotic syrup, but not getting the IVs, so that we cannot congest like the ward. I think that's what we've always been saying.
But the truth is, what we have been doing in Kasangati, 3 days. It is 3 days. You don't want to create something like, unless the baby you are filled with the cannula. That is when we give the syrup. But the ideal thing we have been doing is 3 days. And that is the only thing we really have to cross-check with the Ugandan building, because I think everyone, even when the doctors here are writing, they really write like 3 days. Yeah. So
I think from what Rachel said, though, I think Dr. Gloria has already checked the guidelines, and it should be 5 days. So I know for space reasons and capacity reasons, it's quite common in Kasangati and other places to only give 3 days. But really, if the guideline says 5 days, it should be 5 days. And then we would make a note to say that because of capacity issues, the baby was discharged early.
Actually, Venetia, among the cases that we have presented, not all cases are finished at 5 days. All of them have early discharge. Like immediately, as Daisy, you've said that immediately the baby gets well, they say that let discharge and they get space for new neonates. So it's still a gap, though we know that there is.
Even our clients, they are staying here for 5 days.
And the baby is breastfeeding and not crying anymore.
Yes, they end up even
Yeah.
escaping from the hospital.
But this will feed into because part of the intervention is going to be training on antimicrobial resistance. And I think if the guidelines say 5 days, it's because of the risk of AMR developing. And so I think it's important to capture that, to be honest.
And
Even though the babies may be getting better after 3 days, if the guidelines say 5 days for AMR reasons, then it should be 5 days.
Having a word for our neonates,
it is not allowed here activities from one stage.
Yeah.
They will get other infections than
Okay. I think we can go to the next. We can go to the next, which was what medication did the baby receive on ward? We have D 10%, Genta, and ampicillin. Then what tests were ordered and done for the baby? None. Then was this baby reviewed in a timely fashion and when requested by the nursing staff? No. Was the baby reviewed and reviewed in a timely fashion? Okay, there was no documentation to show that the baby maybe was reviewed after this time or what. And throughout the baby's chat, it's only the midwife who had seen this baby. That's why we put no. Then was the treatment plan given appropriate? Yes, but like we talked about the 5 days, they didn't follow through the 5 days plan. So yes, but maybe the treatment was not completed. Okay, now this contradicts the next question. Was the treatment completed? No. So we say no. No. Then what further investigations would have assisted with the baby's care? We talked about RBS, and that's something that we can actually do here. RBS, CBC. I think as per our capacity as Kasangati Health Center for maybe RBS and CBC. For the C-reactive protein, that cannot be done here. So these are the tests that we think. I don't know if other members have comments on that. No. Then was this discharge appropriate?
I guess what tests should have been done compared to what is available at Kasangati? Because if we capture that, it will inform our possible guidance that certain tests should be provided but are not available in Kasangati. Do you know what I mean? So we should be following guidelines, not what's actually available. So what tests in an ideal world, according to the guidelines, should have been done?
Okay, besides okay, for the RBS, okay, it's available, but I don't think the strips are always readily available, so they would rather use it on the diabetic patients than the babies who might not actually be hypoglycemic. But since the baby is not breastfeeding, they could be at risk of being hypoglycemic. Then for the CBC, if the baby has had the infection for long, it would show us if they've had that infection, like, or if there is actually a bacterial infection or a viral infection or anything like that. Then for maybe also the C-reactive protein test, it could help us know if that actually it would be the ideal in this setting for us to know that the baby has an acute infection. But I don't even think in Fort Portal they do it because it must be a bit expensive. So maybe we can add that. Then also we can talk about maybe doing a cord swab to see what antibiotics that the baby can react to, culture and sensitivity. He has said any other tests that would have benefited this baby to inform like partners. So that's what I can think about.
What would the guidelines have recommended, Daisy? Do you know?
I'm not really certain of what they would have recommended. I was just looking at the differentials, something that could present like sepsis, but can help you rule out if the baby is having sepsis and can help you with the antibiotic plan.
Yeah, okay. Rachel, from your experience of the case reviews in Fort Portal, what other tests have you kind of discussed in the past there?
As Simon and Dr. Gloria agreed doing RDT from these neonates, doing CBC and also blood culture. Yeah, and also they're also suggesting RPR, like for syphilis. So those are the 4.
So I'm adding RPR for syphilis. Actually, I think that's actually important in case it's transmitted from the mother to the baby, because a mother having so many infections during pregnancy, they could transmit it to the baby, but also reduce the baby's immunity, making them to be at risk for so many infections. So I'll add RPR as well. And you talked about the other one?
Blood culture.
CBC, blood culture, RPR, and RDT. And in case the neonate is discharging past from the cord stamp or from the cord, maybe you can do a culture, a pass swab, still for culture and sensitivity, same as blood.
It is for malaria.
We need a pediatrician.
Then pass swab. Okay, I think we're okay with that question. So was this discharge appropriate? We've said no. As per the antibiotics.
Yes, I would say no because of the antibiotics, and also it doesn't sound like a complete set of vitals was taken, which I think is usual. I think the guidelines would suggest that a full set of vitals should be taken prior to discharge.
Yes. Then what was the grade of the person discharging? Enrolled midwife? And could any other care have been beneficial? I think routine monitoring of vitals. What else? Maybe review by the MO. assistant. Proper documentation. What else? Patient
Answer, follow-up.
follow-up.
You're doing it.
Antibiotics.
Or
Since we say that she gave birth from the TB and the IPC, we are not sure of the IPC, so she would have maybe benefited from the antibiotics.
for the mother.
For the baby.
The baby was already getting antibiotics. The mother who was delivered from there and all that, just for her to do.
Yes, any other care? Okay, so we go to the next question. Noted points of good practice, proper diagnosis, proper treatment. Maybe
Survival treatment.
maybe antibiotic treatment. Counseling to the mother, giving next appointment, timely treatment.
One, yet you didn't finish the treatment.
No, it was
Maybe timely initiation.
Yeah.
Timely initiation of treatment. Then giving next appointment for review. Counseling of mother, this is 2 times. Usually when the babies are being discharged, the mother's always come in at 6 days for review as a standard. So she was given a review date, and that was a good thing. Then treatment of the baby was documented. It was not complete, but whatever was given was documented as the patient chart, and that was a good practice to note. Any additions? Nothing good that. Then did this patient receive the best level of care possible within the constraints of this setting? Yes.
We are feeling ourselves. Yes. James should give us a yes.
My only question would be the vitals again, at least the ones that could have been done without, well, with the equipment that you did have. It doesn't sound like vitals were done as often as they should have been, even with the limited equipment that you have. Or at least documented. We don't know whether they were done and not documented or whether they weren't done, but. Oh, well, Rachel, what do you think from Foot Portal perspective? What have you been completing for this question when vitals haven't been done or documented as often as they could have been?
Yeah, actually what I can say, what I can say is for us here, we don't have thermometers to use on units. So our answer there it has been a no. Like most of the cases on that question has been a no because of the vitals and the documentation.
You guys want to mark yourselves very highly.
But when we look at this
room.
case, when I look at this case, it's a no.
So we
This is why
are saying
you don't allow students to mark their own homework.
so why for IS we had said received dry treatment and recovered. But we've now said that the treatment plan was not followed according to the ideal guidelines. So I don't know if we're changing this. What do members think? You know, people are tired now, but we need
No,
to
maybe like me, I want some clarification. When you look at this case, this mother first came in after realizing that the baby had high temperatures. But when she reached here, we first exposed the baby and the temperatures normalized. So was it good like for this mother to be sent back home? Maybe we would have kept this mother the baby for observation.
You're not also sure if she ran away. It's a possibility of running away.
With the exposed she picked up. Remember, we also don't want irrational use.
Because when you look at this, like she brought the baby from that same day.
We say we don't want to use irrational use of antibiotics. First exposed, maybe they kept the baby.
And I'm like, do we have first kept this baby around? Observation.
So you feel like there was a delay.
That is not a delay. You cannot term it as a delay.
Now that she came back.
One of the things is when she gets those persistent high temperatures, you really confirm with some sepsis. But since it was managed to a certain point, she has telling her go back home. It means the baby had improved, the temperatures have dropped.
So are we saying no or yes? We had said no. We had said yes, but this baby did not receive the right treatment. That one we have agreed. But the baby recovered. So maybe we shall leave the baby recovered.
Okay.
I'm not sure.
Maybe has
Are
never
you
come
sure?
back.
Maybe died from the community.
No.
Is there any follow-up?
Yes, they came back for review at 6 days. Okay, we're done now. Okay, any other question?
Rachel, from an objective point of view, considering you're outside of Kasangati, what would you say?
Richard does not want to crucify us.
Rachel is being shy now. She's a politician.
No, I'm not a politician, but I say that according to this case, if we look into that question of did this patient receive the best care, we could say no, because we are looking at as Stella is saying that maybe the baby died from the community, and another colleague from there said that we would have kept the mom for some time long to monitor. So I would say no.
They came back for review.
Did you
Are
see
you
them?
sure? Let's be sure.
There's no evidence.
And on top of that,
If she came back for review and the baby is fine, then
Dad, if you're sure,
There.
you discharge that baby on Tolo. You'd have said on phone, but now you said it. Then we are canceling that out. You see?
So we are saying no. We're saying no because of what we had said, despite the fact that we have some of the equipment like the stethoscope, clocks on our phones and all that. There are some vitals that we did not really take. And this is a baby who had come in from like a community. So if you come into the health facility, we should ideally give you better care than what you've been receiving in the community. So if this baby had any other complications, would have easily missed them out. Yes.
Yeah.
So maybe
to me, Daisy, I think that is fair. I think that is true.
Maybe asking a question is, in the notes, was examination done to see whether the mother got a tear during delivery? Things of
yes.
that kind, because whether it was repaired from the ward or the TBA repaired it. Since that
Yes,
even
so-
she didn't get an antibiotic. So we don't know if she got a tear, as the wound healed well. So
she did not get any complications as the mother, but it's not really written, but I don't think someone can take care of a baby without when a mother is bleeding.
They didn't examine the mother.
No, we did not
On reaching
examine.
here.
The focus was so
On
much
the
on
Focus
baby.
was on the baby.
But I feel like someone could ask, how are you now? Are you
They
okay?
focused on the baby.
Baby.
Mama, baby.
Yeah. So there is no documentation of that. We cannot confirm and stand on our ground and really say she was examined.
mm.
Yeah.
So it still
So-
stand as a no.
Okay.
It seems to me that if it's not I guess we don't know, do we? Maybe it was documented, but it would be in the mother's notes, right? If she was examined or if any complications were found. Daisy, how did you know there were no complications if you didn't check the mother's notes?
We gave her a call. I know we had said we are not supposed to be calling the clients, but we gave her a call as following up and also asking for some information like how she was doing and some things that we had not understood, especially for the TBA. This mother was actually admitted late in the night. So, and over the weekend. So as a follow-up, we called her, but asking information within the constraints of no more questions you would ask in a facility when a mother comes in.
Okay. We could always maybe leave it, maybe in that next box below, Daisy, you could add in any other questions. You could just make a note. It is unknown if the mother herself received further care.
I don't know. Any other questions?
I think just in this box, Daisy, it might be good just to note a couple of the discussions we had before about the kind of system, the fact that it was a TBA that delivered the baby and provided the initial care for the mum, just in case, when we're scanning back through these notes in future, if we don't read it alongside the case notes as well, that it might be a bit confusing what happened here. So yeah, just a brief explanation of the fact that it was a TBA. Perhaps also that the mother was recommended a C-section and she didn't, and she ran away. I think that's quite important.
Yes. Any other notes? Hello.
Not from me, no. Unless Alan or Alan or Rachel has any comments, or anyone in the room there with you, Lauren or Doreen or anyone else.
Any notes? Comments?
On my side, it's a no because I think we have captured everything.
Okay. And then action points from this case review.
It sounds like it might be worth just reviewing the guidelines again that we discussed before. I know Dr. Gloria has already advised about the antibiotics and it being 5 days, but Stella, I think you seemed a bit unsure. So I can't see Stella anymore. Maybe she's gone. But it might be worth just checking.
Yes. So the time frame and the staff member. Stella, are you okay? Are you okay?
I think Stella volunteered. She put her hand up before, so.
I'll check that. Agree. I feel like it would really make more sense if I check it.
Okay. The time frame.
I can just even check it today. So it's just 1 day.
I give you 1 day. By tomorrow is 24. Okay. Yeah. 1 day. We shall get feedback in 1 day. Any action points? Any other action points?
I don't think so, but I've actually got just one more question. You mentioned that you received a thermometer or some thermometers recently. Was it just one, or and where did it come from? Was that from the central facility budget, or was it provided by someone else? Because that was one of the things we were considering purchasing, wasn't it, Daisy? And I know you looked at some costs before, so is that no longer needed?
I gave them the thermometer. I had 2 thermometers, so I really provided one, and should be really like. There's also always a procedure where they will have to hand over the one on day duty, handing over to the one on night shift, and there is also with thermometer.
Mine.
So there is enough thermometers. The only problem was keeping one thermometer with one person. So the night people were really missing out the temperatures for the baby. So it was kind of like only day shift and maybe some evening members. So the one now they have to, I think.
So I gave them and Stella gave them one. So they have 2 thermometers now. Yes. So we just need to see how they can be handed over and accountability. Like they don't get
Okay, thank you.
Yes. Any other concerns?
Nothing from me, thank you, Daisy.
Yes, maybe I wanted to read the comments from Ellie that she sent. Okay, even from the previous presentation, but I think they are similar to what we've always discussed. She had concerns about vitals being done on initial visit. Midwife speaking to the doctor, because this case is only a midwife who had seen the child. So if a doctor could come in and review, but I think we've had discussions on that. And she was asking if this can be a standard practice where a midwife always consults like a doctor, but within our settings, I don't know if that is always possible. Then also antibiotics given. antibiotics given. She was saying we had talked about like 5 days, but this was 3 days. Then, yes, if this baby was seen by a doctor. So I think it's within our discussions. Yes.
Yeah, I think we've captured all of that, haven't we, Daisy? So that's great. We're all in agreement.
I don't know if we have any other concerns. Maybe on the document, the records, like in the email. Documentation has not been easy here, so we may not get as good information like the people of photo who have an issue that is fully running. Then we, for the neonatal death review form, they are using it. I think they even had a case last week. Yes, they had a case reviewed last week, an audit. So they are using the audit form. Then we put in a requisition for the newborn inpatient register. That's a standard HMIS2 that's used across. So we also want to see how we can get it here so that all the babies that come in who are sick, whether with sepsis, jaundice, anything, they're actually recorded in that book so that even if people come months or years later, they can actually have a register that they can look at and backtrack information. I don't know what other things from the other meeting. The one that we sent to. I think
that sounds great, Daisy. I'm glad that you have the records now. It seems like the records will improve over time. So yeah, I think that's great.
Risha, you had a comment?
No, I don't have anything to say. The only thing is that thanks so much, team, for the good presentation.
Thank you.
Yeah.
Thank you. So, James, you had also advised that we have 2 more cases. So I think we shall have 1 more case here. The next one shall discuss when it will be presented. Then we shall see the next step.
I think we said 2 weeks, did we?
But
3 weeks.
when the starts, we shall look at the schedules of the local staff and see when they can both be available. Yes.
Okay. Well, yeah, I'll leave that with you, Daisy, to liaise with Doreen and the team and decide. Let us know.
Alan, did you have any comments?
No, I don't have any comments, but thanks for the good presentation.
Okay, thank you so much for attending. If we don't have any other comments, I think we can call this a meeting and some other people can enjoy their lunch. Thank you for the facilitation. Meanwhile, for the lunch, Alan. Yeah. Okay.
Enjoy the lunch then.
No
Glad to hear that you
problem.
have some food today.
Enjoy.
Thank you.
Thanks, everyone. Speak to you next time.
Thank you.
Bye.
Bye.